All right. Good afternoon, everybody. Welcome to another series of Grand Rounds. We have lunches in the back. Please don't forget to sign in so we can continue to keep track. Today, we have our first external invitation, and we are extremely excited to have Manreet Kanwar here. I'm going to have Dr. Supriya Shore come and introduce her. So big round of applause.
Good afternoon, everyone. Thank you for joining us. It is my great pleasure to welcome today's Grand Round speaker, Dr. Manreet Kanwar. Dr. Kanwar is a professor of medicine at the University of Chicago, where she also serves as the director of heart failure and pulmonary hypertension, and is also a co-director of the Heart and Vascular Institute there. Prior to this, she held several leadership roles at the Allegheny Health Network, including being the chief academic officer. She's a national leader in cardiogenic shock, as well as durable and temporary mechanical circulatory support. In short, she's a trailblazer, a researcher, a busy clinician, and most impressively, she's managed to accomplish all of this without needing any augmented flow with any kind of LVAD. She is our answer to critical care cardiology. Thank you for joining us, Dr. Kanwar.
Thank you, Supriya. That's made me sound more confused than accomplished. Good afternoon, everybody. Thank you so much for having me. I trained in Detroit, Michigan for my residency and fellowship. So coming back to Michigan, every excuse I get feels awesome. So as Supriya was mentioning, I wore many hats. I started as a PH physician, then became more interested in VADs, then got distracted and got interested in temporary MCS and hence cardiogenic shock, which has been area of my focus for the last, I would say maybe 5-6 years or so. Primarily initially clinically, because our shock team, our shock program was, kind of non-existent, a little bit of everything thrown in, and trying to give it shape and structure, which by the time I left Allegheny, I think I was very proud of the program we have achieved, and now we're trying to do something similar at U Chicago with the history that we have. So over the next maybe 30 minutes or so, I'm going to talk about the field in general. And in talking so, I'm going to be wearing the lens of my role in the cardiogenic shock working group, and I'll tell you all about it as soon as I figure out how to move this forward. She only gave me instructions once. Okay, so of all my disclosures, the one that I'm most proud of is that I'm a member of and one of the steering committee members of what is a cardiogenic shock working group. And I'll tell you a little bit about it as we speak. I run it with one of your old alumni, ex-alumni, Shashank Sinha. And I started this journey approximately 6 years ago, and it really changed how I practice shock medicine, how I look at literature, frankly, or shock literature going forward. So I'm going to be talking about where we are as a field in shock and where we need to go, in my opinion, from the lens of my work in cardiogenic shock working group. By no means does it represent to say that we are the only folks working on it, but I'll try to weave that as a story. So, like all, I think, talks, I wanted to start off with a heart failure story. This is one of my patients. His name was Ken. And Ken, this is approximately, I would say, 2019, 2020, maybe five years ago. This was at AGH. This is a gentleman who came in with a good old anterior wall STEMI. He was revascularized appropriately. He had an Impella CP, which was eventually discontinued, but his EF was around in the 20% range, was not tolerating any GDMT at this point. But everything looked okayish. So the Impella was removed, but he just did not look good, not that anybody could put their finger on it. So as a heart failure person rounding that week, I was consulted. I met him. He seemed like a gentleman who would have been an excellent candidate for advanced options, but we were still talking about it because he looked okay. Again, he was not in shock. He looked shocky, my least favorite word in cardiogenic shock vocabulary. And while we were still chit-chatting about it, what should we do? Should we do this, but that, but this, but that? He had a cardiac arrest. This was late in the evening. We all tried to go in and resuscitate him, including putting him on ECMO, although it was a little bit too little too late, and he passed away. And this is hardly an unusual or a unique story. We see this day in, day out. But for me, it stayed with me because he was somebody I thought we could have helped, but more importantly, I thought he was somebody we should have helped. We just kept talking about it. We were not doing anything about it. And that kind of led me to say is, decision making in cardiogenic shock, when it hits this inertia period, can make a patient decline in front of your eyes while you're still trying to figure out what to do. And that to me was my pivot point clinically to say, I need to do something to make it better. And we see this reflected in all aspects of cardiogenic shock across the nation, across the world. Cardiogenic shock still has a very high mortality, which hasn't really changed in the last several decades, regardless of the number of toys we have to play with in this age and day. So if you look at all comer shock mortality, the needle for AMI shock has remained at about 50 to 60%. The needle for heart failure shock with advanced options has improved to a degree. But if you were to put it all comer together, cardiogenic shock remains a very highly morbid and mortal state with really not much meaningful change as a whole. Now, certain institutions, certain endeavors, missions, or whatever we call them, have allowed us to see improvements, which are very encouraging. But then when you look at it in a bigger picture, in a community hospitals, the shock mortality has not really moved a whole lot. So I'll try to bridge my journey, not just where we are and where we need to go, but take it a step back and say, how did we get here so we can learn from that pathway to direct our future, not just try to reinvent the wheel. So, 1976 Forrester classification talked about looking at patients whether they're cold or warm, wet or dry. Very simple 4-box approach, but not just their physical exam finding, but was also associated with prediction of mortality. So if you're warm and dry, you're probably going to do okay. But if you're cold and wet, the likelihood of mortality is north of 50%. And this focused on the two of what I believe are the three pillars of cardiogenic shock: congestion, perfusion, and hypotension. So this focused on congestion, cold, warm versus, so dry versus wet, and then hypoperfusion, cold versus dry. Now, fast forward to 1990s when we started doing our first shock trials. The definition of cardiogenic shock in the shock trial was the systolic blood pressure less than 90 for a persistent period of at least half an hour was sort of the clinical definition. And then it also had some hemodynamic criteria. Now, mind you, this is an AMI trial, and since then we've only primarily done AMI trials. So when we talk about this definition, it looks at shock as being presented in AMI. But when you try to extrapolate into heart failure shock, the same definition may or may not hold. So this particular definition looks at hypotension and congestion, as opposed to the Forrester classification, we looked at congestion and hypoperfusion. Now we know that an AMI patient usually presents as an hypotension. They then get congested and then hypoperfused as well. Whereas the heart failure patients walk around perpetually hypotensive, usually congested, but the tipping point often becomes the hypoperfusion, which is often triggered by an arrhythmia or infection or just end-stage heart failure. So none of these definitions are capturing, in my opinion, all three pillars of shock. They're still focusing on the AMI aspect of shock. And that's, I think, one of our issues is to define shock. We try to pull from what we know and extrapolate it to everything else, and it just doesn't always fit. Now, fast forward 2023, a shock definition of shock was released, and we are still using the exact same definition, even though we have learned that heart failure shock and AMI shock are two very different beasts. So, when I started at U Chicago, every month that I round in the CCU, I ask the fellows the same question: how do you define cardiogenic shock? I get the same answer: low cardiac index. And I always tell them, swans are a luxury of, tertiary care center. We cannot define shock with a swan finding. Yes, you can phenotype and quantify shock with that, but shock is still defined by the presence of hypotension. But in the patients with heart failure shock, also with hypoperfusion and degree of congestion. So again, how we got here. Over the last 2 decades, we have learned a lot of what not to do, what doesn't work. Milrinone, so the DOREMI trial taught us milrinone and dobutamine are equivalent. The ESCAPE trial, even though it was never done in a shock patient population, but again, we keep extrapolating it, showed us a FACC or SWAN has no benefit in the absence of SWAN compared to the absence of SWAN and outcomes. Intra-aortic balloon pump, ECMO, literally trial after trial after trial becoming negative and telling us what we do, what we shouldn't do, but very little on what we should do. So how do we take care of the patient in front of us? Intra-aortic balloon pump has had this love-hate relationship with our practice. At least for the last decade, it was a class 2 indication. It was downgraded to a class 3 indication by the our European colleagues, and it said it should not be used. So in many when I speak in Europe or in international societies, they all look at me strange, and why would you use an intra-aortic balloon pump in this age and day? Yet in United States, it is the number one temporary MCS device used. So there's a huge discrepancy. So then we get into the argument of what's the evidence behind it. And the argument to counter that is there is no evidence in heart failure shock to use anything. So how do we decide which one to hate or love? So overall, as a temporary MCS and AMI shock, IABP has seen a huge decline. But if you look at all-comer cardiogenic shock, intra-aortic balloon pump still reigns supreme in the United States, although that trend is starting to decline. Now, more recently, the first ever heart failure cardiogenic shock trial, which was the ALT-SHOCK trial, was released again as a negative study. Now, you could argue, the pros and cons of how this study was done, but we continue to have zero data to support the use of one therapy over the other in heart failure cardiogenic shock. And of course, ECLS shock, again, made a lot of headlines when it said, oh, routine use of VA ECMO in AMI shock is not to be used. But then they pitted it against medical therapy and found these results that have been since replicated a lot of times. But if you think about it, is this really the patient population we are trying to fix? Now, almost 100% of these patients had altered mental status. Nearly 3/4 of them had been resuscitated. Their median lactate was 7. So this is a very, very sick patient population. So yes, ECMO doesn't help very, very sick patient population, but does it mean it doesn't help anybody? We can't extrapolate ECLS shock to say ECMO is bad in cardiogenic shock, or for that matter, danger in STEMI shock to say Impella CPU should be used for everybody in AMI shock. So our trials continue to be very limited. Of course, danger shock, I'm sure you're all very familiar with it. The first and only positive AMI shock trial showing benefit of the use of Impella CP in STEMI shock specifically was improved survival compared to standard of care alone. So a long list of trials, which we keep adding to, continuing to show neutral results, except for danger, which barely made it to the favor MCS side of this forest plot. So unfortunately, I think unfortunately, our guidelines not to be left behind followed suit. They said use of Impella class 2A indication, use of intra-aortic balloon pump and ECMO class 3 indication, no benefit should not be used. Now, has this translated into clinical practice? In Europe, you will not find an intra-aortic balloon pump in most nations. In the rest of the world, you won't find an Impella 5.5 because it's an expensive device to be able to be used. So we continue to do what we do, but in a way, we are not following our own guidelines to say, do not use intra-aortic balloon pump and ECMO. Now, but how does this translate into real life data? Now, this is data from Shock Working Group. Shock Working Group is a conglomeration of about 50 centers, 45 of them in the US, 5 of them outside of the US. And we follow patients. It's a registry. It's a shock registry of all comer patients, regardless of whether they get temporary MCS, whether they have AMI shock, heart failure shock, post-cardiotomy shock, et cetera, et cetera. And what we see is year after year after year, the same patterns. 50% mortality in AMI shock, about 40% mortality in heart failure shock. So we continue to not see the change we would like to see with all these options available in real world registries. Now, part of the problem, I think the randomized control trials continue to be negative in this arena is we keep following the cookie cutter design. We say pitch one therapy against the other, leave everything else to the discretion of the PI and hope for the best. And I think this in itself is a fallacy in trials because we all know that the initial decision is not all that matters in cardiogenic shock. If a patient worsens, you have to escalate. If a patient improves, you got to de-escalate. If a patient has an invasive therapy, you got to take care of that, and so on and so forth. So if you have no algorithms of care and just say it's going to be IABP versus Impella or ECMO versus whatever, then this premise is, I think, the setup for failure for these trials. So I call this the cookie cutter trial design. IABP shock followed the same, no protocol once the balloon pump goes in. So beyond that, to each their own. Impress trial, which was CP versus balloon pump, the same problem. Danger had some protocols, but really not beyond a point. ECLS shock also had very limited protocols. The first trial that was supposed to test the hypothesis of protocols is what matters, not just the initial device therapy, was Recover 4, which was canceled by the DSMB shortly after danger results were released. So we'll never know. So as a result, these are our shock guidelines. I mean, shock is one of the highest, most morbid mortal disease, and this is the best we got. We think inotropic support helps. Which one over the other, we don't know. We think temporary MCS helps. We think a PAC should be considered. This is another issue is in the tertiary centers, such as this one. I'm sure that rates of SWAN utilization is very high, but shock doesn't live in tertiary centers. Shock lives everywhere. And it's a class 2B indication, just one above 3. And it won't take much to slip to 3, because if we have no data to support, we have lots of opinions, but no data to support the use of SWAN, then we are not really necessarily making a case for the use of SWAN beyond our own center. So as a result, this is where we are at. Now, this is real world registry data for propensity matched patients across the 7 or 8 biggest risk factors to predict mortality in shock. I won't even tell you what the blue dot represents because it doesn't matter. These similar looking patients will get literally just about any number of devices in any sequence in no particular order. So we have no consistency of how we provide care to these patients. It depends on the time of the day of the week, who is on call, where is the patient, as opposed to what does the patient need. So I think this is the biggest issue with cardiogenic shock is our decision making. We have very strong opinions about it, but little data to support the use of one over the other. So this is a slide I borrowed from my shock mentor, Naveen Kapoor at Tufts, now at Abiomed, in breaking the paradigms in cardiogenic shock. So the first issue is you have to define the problem, because if you don't know what the problem is, how can you ever fix it? Then we have to remove our own bias from understanding of shock, because we all have somehow very strong opinions of what should or should not be done. Then we have to focus on algorithms, and not just to say dobutamine versus milrinone, but then what beyond that? If the patient is not doing better, what is the next step? And that has to be standardized across board so that we can follow and understand that did that work? Because right now we don't particularly or necessarily do that. Recognizing the use of temporary MCS as much as the futility of MCS. Not every patient can be saved. So putting our most invasive, expensive resources, including our ICU beds, on patients who just cannot be salvaged, but then you're left with this, they're neither dead nor alive situation, takes up a lot of effort and energy. So recognizing, we always get this emotional, if we say you shouldn't put this patient on ECMO because it's going to be futile, to say, hey, you want my patient to die? And the answer is no, I don't want anybody to die, but they're going to die regardless. So knowing when to say no and when is too sick is, I think, a key factor. Enhancing the cardiac critical care shock talk, because at the end of the day, we need the best of all of us to be able to take care of these patients, and then generating real world evidence, which will then help us decide what questions we need to answer, because otherwise we will keep circling the drain as we have been for the last several decades. But I think the crux is the willingness to execute, remove our bias. We should not say, okay, I have decided I like Impella 5.5 or I like counter pulsation, so everybody gets that device, so help me God. So willingness to be a part of the scientific study, the relentless pursuit of data, which was sort of our mission statement when we started. So with that, I'm just going to introduce you to what Cardiogenic Shock Group is. I've been referring to it a little bit because we set off this mission about 6 years ago now, or maybe 7. Started as a brainchild from Dan Berkhoff and Naveen at the time at Tufts. And then he asked, so Shashank, I'm sure many of you recognize, so about 7 of us came together brought our centers, individual centers data, and our first goal was to get to 100 patients. And we were like, oh my God, if we had 100 patient data, we will go crazy. We crossed that landmark very quickly. Then we expanded it to 1,000 patients, which we got to also very quickly. And this is all, even though Shock Working Group is funded by industry, but it is not in the sense that all the money goes to Tufts, which is the CRO for us, and then none of the programs are incentivized or paid, or any one of us for that matter, to enter data into the Shock Working Group, except for CRC's time that is worth for that. So this was our mission statement. We wanted to improve outcomes in cardiogenic shock by promoting rigorous scientific investigations, by starting with this multi-center registry, because we said we need to have some real world data to help us define our next problems. We are now, our steering committee is now with four young ones here, including Elric, Quay, Song, and Rachna. Again, just to keep up with the needs for our shock working group. So we started as in around 2019 with about 2,500 patients. We thought we'll first understand this from a retrospective study. This was the mission statement Naveen set us all these years ago, which was supposed to expand then to about 5,000 and then 7,500 patients, where we were going to launch our prospective registry, which we did in 2022. And then we developed our first nested RCT, which we'll talk about in a second. And then we thought by year 5, we're going to grand retire at 10,000 patients and then expand to the rest of the country. We have crossed all of those milestones many times over. We have the world's largest cardiogenic shock database from real world registry collected, out of sheer labor of love from all these centers, which has allowed us to now move forward from these initial 5 centers where we started to about 50 centers across the world, mostly, of course, in the United States. And this was our founding sort of Edward Denning quote that we used is, again, not that many of us are particularly religious, is just, again, it has to be data. Our opinions need to be left outside at the door, and we have to be able to bring information to the group. And of course, we get together every week. We have 2 one-hour long meetings where we talk about, how to do this project and that project. And then subsequently, we get together as often as we can. And the academic productivity of this group has really taken off in the last few years. We've published over 50 original science papers in various journals since 2019. We started our first RCT, which was FACC, which is the use of SWAN, randomized to SWAN in heart failure shock, SWAN versus no SWAN. And then we just got funded for our first R01 this year, where we are partnering with Beth Israel with their machine learning folks to basically try and understand risk stratification in shock. At this point, we have about 14,000 patients from 45 centers entering data of their consecutive shock patients into this registry. So most of my next few papers are going to be talking about shock working group. What is the time? So I just don't run over. Okay, super, I'm on time. So the first thing so this is just an example of the few of the papers we have written and why we wrote them, so that it kind of makes sense. So I wanted to weave this as a story or as a journey. So the first issue, again, to fix a problem, you have to define it. And to define it, you have to define shock. And, shock vocabulary for the longest time included terms like shocky or train wreck or pretty bad or pretty good, which of course is very, very subjective. So Sky released this classification in 2019. And then interesting story that David Barron, the first author, will tell you that almost no journal at the time wanted to publish it because they said, what's the point of this? Who needs this? So he ended up publishing it in Sky, which at that point was not even PubMed index. And now it's the most quoted, I would say, pyramid figure in shock literature at this. But even with this vocabulary, the issue was it is rather subjective. Were deteriorating, in my opinion, may be different than my surgeon's opinion of deterioration because it's a subjective term. Similarly, beginning, at risk, who is at risk, so to speak. Extremist is a little hard to ignore because we all agree somebody in cardiac arrest on ECMO is kind of extremist shock, but everything else was still relatively subjective. So this is one of our 2023 publications, I would say, where we took the sky stages and gave it parameters. So we call this this is sky staging of shock, but we call it the CSWG sky staging, also available in an app. I think I have that figure up here, is to take the exact same sky staging and we gave it parameters with vital signs. And if you'll notice, there is no SWAN hemodynamics here because we recognize that SWAN is not something that is prevalent in the community. So just lactate, pH, if I were to have two things, and then whether you're on temporary MCS or on devices and drips, because if a patient has a systolic of 92 on levofed versus a patient has a systolic of 92 not on levofed are two very different patients, so to speak. Not only did we define shock as its stages or try to give it a very distinct metrics, we also tried to associate the trajectories of shock, which basically means if you come in as a sky B shock and you deteriorate, you are going to have a much higher mortality than those who present in sky C or D shock and then stabilize. And why is that? We think it is because it's hard to ignore sky C, sky D shock because they're sicker. It's a sky B that comes in, lingers for a little bit. Eventually, somebody realizes they're in shock. And now we try to throw a kitchen sink at them. That patient has a less likelihood of survival than those who were appropriately managed upfront. So we call this the B is for bad analogy is, I think this is the scare, just like sinus tachycardia, in my opinion, is the most worrisome arrhythmia because it is telling you something is wrong. You just haven't figured it out yet. Sky B shock, similarly, again, is once it escalates, it is very hard to turn that around. So early recognition of cardiogenic shock, I think, is key. And to be objective about it, our recommendation was is all patients with decompensated heart failure who are getting admitted to the hospital should get lactate levels checked because you'd be surprised how many times they are in cardiogenic shock and we don't even realize that. This is the app available to download. I don't let my fellows round without this because I tell them every day you got to stage shock, not just at the admission, but at subsequent periods down the line. Because if you go from Sky B to D shock, your trajectory is going to be again much worse. So we round with this app, whether my fellows like it or not, too bad. So the second point we wanted to emphasize is the type of shock matters. So this is a slide I borrowed from Babar Basir at Henry Ford Hospital. At the top, he's describing three different patients who look very similar based on their EF, their vital signs, and even their labs and SWAN hemodynamics, but they're three very different patients. The first patient has chronic heart failure, the second patient has AMI without cardiac arrest, and the third has AMI with cardiac arrest. And even though they may look similar in the stem, they are going to have very, very different trajectories, very, very different mortalities because one is compensated for a long time, the others don't. So recognizing that it's not just the vital signs or just the lactate or just the cardiac output that's going to define their trajectory. So again, phenotyping cardiogenic shock in addition to staging cardiogenic shock, I think was another one of our sort of key observations. We were, I think, as a group, one of the first to define heart failure shock in more and more detail because till that time, all data focused on AMI shock because that's where all our randomized controlled trials used to sit. And not just heart failure shock, but splitting it into de novo, new onset shock versus acute on chronic end stage heart failure shock and recognizing that these are two very, very different beasts. And also the way we treat them is very different. We just kind of throw random number of devices at them and hope that they will work, which was all one of our initial observation data, so to speak. So we realized that heart failure shock is under-recognized, under-defined, and therefore the pathways to how to manage it are very, very underdeveloped. So we sort of took this as our mission statement. So this was probably, it's funny, it is out of all CSWG papers, this is the most quoted paper we have for phenotyping shock. None of the journals, it took us 7 to 8 attempts to convince an open access journal to eventually publish it. We had to pay like $4,000 to get it published. And now everybody talks about phenotyping shock like we were born for it. So this was our first attempt at machine learning phenotyping shock. We used k-means clustering to say it almost doesn't matter why the patient was in shock. So we took three sort of patient groups, non-AMI shock, AMI shock, and then an external validation cohort in AMI shock. And we found the exact same pattern repeat itself over and over again. We called it cardiometabolic shock, sort of saying the heart is involved, the lactate is high, the liver is involved, the kidney is involved. Very different than cardiorenal, where less organs are involved, very different than just cardiac issue. Now, it sounds kind of obvious that more organs are involved, the sicker the patient is, but to recognize that this is a distinct phenotype and whether the patient is coming in with AMI shock or non-AMI shock, being in a cardiometabolic state is going to be associated with a much higher mortality, was something that we had to show using this K-means clustering. And we were then able to associate these three distinct phenotypes using these radar plots, which are basically showing you that all hemodynamics of cardiometabolic shock, all labs of cardiogenic shock behave a certain way. And learning to recognize these patterns, which are obviously easier to do with the machine, are associated with an increasing, with different, very, very distinct Kaplan-Meier curves. And as you can see, the split happens right away for survival in cardiogenic shock. So this is all work by Ulrich Zueck, who who's actually a medical student at the time he wrote this paper and is now a cardiology fellow in Hamburg, in Germany, in Düsseldorf, in Germany. The third thing we sort of try to emphasize is RV matters. We keep talking about LV shock. All our machines, all our devices are geared towards LV shock, but we often under-recognize how sick the right ventricle is and under-support it. And now it kind of seems like, duh, of course, we know RV matters, but this was our first CSWG publication where we reported that presence of RV failure is seen in 50% patients with LV failure. So in other words, 50% of all cardiogenic shock presents as BIV dysfunction, which we defined as a CVP above 20 in this patient population. And this is associated with much worse survival than if you purely come in as an LV shock. So recognizing the effect of RV dysfunction on LV shock was probably our first initial contribution as well. And then, of course, the devices. RV devices are still, I think, in flux on how we use this. You looked at all patients who underwent any kind of RV temporary MCS devices, whether it's Impella RP, Protect Duo, ECMO, etc., and try to understand the key differences between them. In this paper, again, led by a medical resident from Tufts, Kevin, who's now finishing his training at Emory at the time. So Rashad Giran, currently at Beth Israel. This was my first paper I wrote as shock working group with Rashad, where we showed that use of FACC or SWAN is associated with improved outcomes in cardiogenic shock. Of course, this is registry data. This is never going to impact guidelines, which is why we sort of are trying to do it as a prospective registry, because showing associations is just that. It is showing associations. It does not necessarily prove the point. So this was one of the first papers that talked about the use of SWANs associating with improved outcomes. And then, of course, all the escape police came out, and we had to actually write a paper called Escape from Escape, reminding people that the escape trial did not include shock patients. It only included patients with decompensated heart failure, and we should not try to compare the two results. We were then able to show that not only is it the presence or absence of utilization of SWAN, the earlier you use the SWAN, the better the outcomes for this patient. So this was a paper I led with Vanessa, who was, I think, a Cleveland Clinic fellow at that time, where we looked at, from the time of onset of shock, how quickly did the patient receive a SWAN, and associated with it with use of temporary MCS therapies and also outcomes. So 6 hours was the window where we said if they get a SWAN within the first 6 hours of shock recognition, it was associated with better outcomes in heart failure cardiogenic shock. We then moved on to sort of this was touted as the golden day that Kuei Ton and Song Lee had presented at ESC last year to so this is a Sankey diagram on the right showing how the patients first presented at 0 hour, whether they were SCAI, B, C, D, or E shock, and how their trajectories happen not just at the time of presentation, but at the first 24, 48, 72, and the end of stay. And what you will notice is what happens in the first 24 hours kind of dictates the show. So first 24 hours, we call it the golden day of shock, is to say, and also recognizing that stage B, SCAI B patients who present in that, their trajectory in the first 24 hours is the most tumultuous. And if they deteriorate, they are not likely going to survive. So again, putting the emphasis on early recognition of cardiogenic shock and early therapies, because if you're going to not do something in the first 24 hours, chances are the patient is not going to do well in the time period to follow. So timing in shock matters. This was probably one of our more recent publications, again from Elric and Quay, talking about serial assessments. Shock is not just about initial risk stratification. You got to keep looking at them. And what he was able to show was that it is actually, I don't have that figure, it's not even just the first 24 hours, it's the first 6 hours that kind of dictate the outcome of the patient. So putting the emphasis on early recognition and upfront therapies. I was a little surprised to learn today that at University of Michigan, you don't get a lot of shock transfers because many of the hub centers get 50, 60, even 70% of their shock patients transferred in. This was a paper Rachna and Rishad Garan led into what is the outcome of those transferred in versus who presented primarily to the shock working group center, to show that those who have transferred, not surprisingly, had higher mortality than those who presented primarily into the shock working group center in this particular analysis. We also said, being a woman, this is again a topic of increasing relevance now, is to understand the gender or sex, the differences in cardiogenic shock outcomes. We found that women were as likely as their male counterparts to be diagnosed with similar. So the SKY staging was very similar, but they're less likely to be transferred. They're less likely to receive a SWAN. They're less likely to receive temporary MCS therapies. And when they do, they are more likely to have vascular complications compared to their male counterparts. But those who receive VAD or transplant eventually go on to do equally well as their male counterparts. This is work led by Jane Farr and Justin Freed from Columbia and UT Southwestern, respectively. This was our first big Impella 5.5 analysis, where we took about 700 patients with Impella 5.5, and we were able to show that if you use Impella 5.5 as your initial therapy rather than escalate to it, those patients have a better survival than compared to those who were escalated to 5.5. Again, initial therapy matters, initial pump choice matters, timing matters, LV BIV dysfunction matters. So pick your therapies wisely, pick them up front. It shouldn't be dictated by the time of the day of the week, but if the patient needs a 5.5 or if the patient needs a whatever it is that they need, use that therapy up front rather than saying, let me throw in a balloon pump, and if the patient doesn't do well, then tomorrow maybe I'll deal with the escalation. That is not associated with as good an outcome as the earlier upfront therapy in this patient population. Now, in the transplant world, we are facing increasingly long durations of support. If you recall, Impella 5.5 is only approved for 14 days of support in the United States. In Europe, it's approved for 30 days. Why 14 days? I'm not really, I tried to follow the thread, but nobody could really answer where the 14 days came from. They submitted to FDA for 30 and they gave them a 14-day permission. But the point I'm trying to make is we are using this therapy as a bridge to transplant, especially in the United States, for exceeding number of weeks. Now, what we were trying to understand here, that what happens to these patients after 14 days? Do they have more adverse events than those who have a shorter duration of support? And in this particular analysis, we were able to show that longer durations of support with 5.5 actually had no worsening incremental AE risk. The AEs were there, they don't go away, but they don't keep going up with timelines as they proceed. And most of the patients received, if they were bridged to heart replacement therapy, were able to receive that outcome or an exit strategy as was intended. Of course, mortality is high in both arms, which is not surprising. And then lastly, obviously with every therapy comes their adverse events. So we had 4 different papers, one focusing on intra-aortic balloon pump, one CP, one 5.5, one ECMO, trying to understand patients who were supported on one over the other. Acute limb ischemia, of course, one of our most dreaded complications with temporary MCS therapies, shown here by work from Ajar and Saras, our 2 interventional colleagues in the shock working group, looking at rates of limb ischemia based on the therapy that they received and what were the risk factors associated with that, because to mitigate these adverse events, you would want to try and address that. Back to balloon pump where we started, we are all believers of balloon pump, if I may, especially in heart failure shock. So this is work from Arvind Bhimraj and Rishad looking at outcomes with use of a femoral balloon pump in AMI versus heart failure shock. And we were able to show that heart failure shock actually has better outcomes with femoral balloon pump compared to AMI shock, shown here in this Kaplan-Meier curve. Just came out, I think, just a few weeks ago. And then we looked at axillary versus femoral. Obviously, axillary is never the primary therapy. We use it when we expecting longer durations of stay or as a bridge to advanced therapies. So Arvind looked at how to compare the outcomes with femoral versus axillary balloon pump. And not surprisingly, patients with axillary balloon pump tended to do better than those with femoral balloon pumps in this patient cohort. And then this is probably, I think this is out, if not in press, is the real world registry data of Impella CP, because even though Danger taught us that it should be used in AMI shock, we can't help ourselves. So we use it in non-STEMI, we use it in heart failure shock, we used it every which way. But what we found is if you use it in indications it is not approved for, surprise, surprise, it has a much higher adverse event profile because you're using it for longer durations of time. And Impella CP, I've never seen a CP not hemolyze after 48 72 hours of support. So again, it's the patient characteristics. So if you have to match the device with the need for the patient, this is work led by Tony Carnicelli at MUSC and Shashank, probably our most recent publication. So to finish up, our most where do we go from here? We keep talking about we need another trial. Everybody loves to say, and we need an RCT. The fact of the matter is shock field is not going to see an RCT in the foreseeable future, the kind that we seek that will answer all your questions all at once. If we talk about can we, in the United States, pit CP against something else, the answer will be, can you withhold a class 2A indication from that patient? What are the ethics of that? So we may never know whether it was ever good enough to make class 1 indication. Recover would have told us, but we'll never know that. So yes, we all would love to see more RCTs. The reality is it is not going to happen. So do we therefore start extrapolating data? Just because the CP worked in AMI, shouldn't it work in, if it worked in STEMI, should it work in non-STEMI? We don't know. Should it work in patients with cardiac arrest who were excluded from Danger? We don't know. How to escalate, when to escalate, what to escalate to. Do various shock phenotypes, should they have different treatment strategies? What about women? Women have traditionally never been highly enrolled, whether it is a heart failure trial or a shock trial. Danger had 79% men, IABP shock had 70% men. Our registries have almost 70% men. So can we say whatever we learn from men can be extrapolated on women? We don't know. So therefore, these are all these gaps that still need to be filled. And of course, a registry is not going to be able to fill all of these, but the whole idea of creating this registry was to inform what questions need to be answered before we start our journey to try and answer them. We are trying to talk about learning about futility of MCS. What lactate is too high a lactate beyond which survival is not going to happen? Is there an age cutoff before beyond which you should not be offering very invasive MCS therapies? Who is to say, every 82-year-old that we talk about ECMO, they're like, but he was playing golf yesterday. And I was like, maybe that's the best way to go. Because if you're going to put an 82-year-old on an ECMO, chances are they are not going to do well. So talking about utility versus futility is something we are trying to decipher using machine learning, which is also the premise of one of our key outputs for the R01 that just got funded. It's a little, it's the PACS trial, which is SWAN versus no SWAN and heart failure shock. Usually at a larger meeting, I always ask people, who wants an RCT in shock? And everybody says yes. And I'll say, who will randomize to this trial? And everybody says no, because they all think that how can you, it's unethical to manage a patient without a SWAN who's in cardiogenic shock, but then where is the data to support it? So we have randomized about 110 patients into this trial. We still have a long way to go. Maybe it'll give us the answer we seek. Maybe it'll surprise us. We don't know, but that's why we do RCTs. And the sad part is at this point in United States, that is the only shock trial that is currently active, the only one. Not industry funded. This is a mom and pop show. We are doing this out of shock working group, but because we are committed to try and find these answers, because we can all want answers, but right now in the US, there is no other shock trial that is ongoing, which is, and it's not going to change in the foreseeable future because nothing is being planned. Now, we also are partnering with various organizations. So, as much as we talk about balloon pump, 5, this, that, and such, none of these have best practices associated with them that are published. So this was one of our first attempts. This is not from Shock Working Group, but many of the co-authors were a part of it. Is we first published what we think are best practices of Impella 5.5, because it is fast becoming in the US the lead pump of choice in management of heart failure shock. So if you are using that in your ICU, something to consider looking at. And also partnering with ERA's, the POCI team, to sort of talk about best practices in the surgical ICU side, because I think post-cardiotomy shock is a whole different animal that we haven't even touched upon. But partnering with different societies, be it ACC, ISHLT, ERAs, ATS, so on and so forth, because we don't want to be in our own bubble to be able to talk to ourselves and convince what we already know. So my partner in crime here, Shashank Sinha, Rachna, and Naveen, they were a part of this ACC consensus, clinical consensus guidance, which I find very useful on levels of shock. And this was their sort of pathway that they laid out. Again, focusing on the first 6 hours of shock, early shock recognition, early therapies, and not wait, with this mnemonic that they had published in JACC not too long ago. And lastly, partnering with workshops. So this last year, or earlier this year, I should say, ISHLT, I am an ISHLT person, so I've been trying to bring shock into that society. We held our first Shock Academy, and next year we got picked again to host the Shock Academy, not me personally, but as a topic, which is the first time that I am aware of in the history of ISHLT that the same topic got picked twice, because there was so much interest in doing these topics and doing kind of hands-on experience, simulation experience, so on and so forth. So to end, I started this this whole lecture with a heart failure story, but then I was able to help translate this into a heart recovery story. So a few years later, after Ken had away, this was another gentleman named Jeff, who was resuscitated by his wife at home, was found to have a STEMI shock, crashed onto ECMO, then vented with an Impella, and was eventually, so I am the person holding the chair behind to keep my daytime job, because I was not particularly good at it. But what I'm trying to show here is that this is the shock reality today. This patient can be saved, is saved. We don't just talk about it, we have been able to make it actionable. This is a patient who, if at 2018, would definitely died. But now we are at a point where we not just are able to do ECPR, we are able to use algorithms which we created ourselves within our programs to help these patients. We routinely mobilize all our patients on femorally cannulated via ECMO, something that was unheard of, a few years ago. And these patients go on to do well. So for every heart failure story, there is more and more heart recovery stories. So this is not just doom and gloom. I think this is the most exciting time to be practicing shock, not because we have all this data, but we have an opportunity to create this data. I know you guys participate in C3TN. What I was telling the folks I met this morning is have data, know your outcomes. So to say University of Michigan's shock survival is X, and then our goal is to increase it by Y, but you got to know your X, and then you can put in the Y. Is have data, then you can learn how to act on it, because otherwise you'll just have opinions about it and not necessarily so. So I'll end with my other William Deming quote. I love quoting him in all shock related. The thing is, we could choose not to do any of that. We can just come into work, take care of our patients, and go home. But we can choose not to learn. But then, learning is not mandatory, neither is survival. Thank you. Questions? Yes, sir.
But I'm really interested in doing clinical trials in settings where there's not corporation, or at least might be difficult. So tell me about the randomization there, which you had a swan within 6 hours, swan, no swan, or after 48 hours. Did you had crossovers? And do you have how have you chosen?
So we haven't analyzed the data yet because we have to reach our 200 mark before we'll do the first interim analysis. But the physicians are allowed to cross over. It's discouraged for routine use. Like, it's not to say that the next day you say, oh, why doesn't the patient have a SWAN? Let's do that. I have personally randomized about 20 patients into this trial. I have had crossovers myself. I've had patients who got randomized to a SWAN arm, which after 24 hours, I was like, I don't even need this information anymore. I can take it out. But more importantly, those who were randomized to no SWAN, who deteriorated. And then I thought, now I should put a SWAN in because my decision-making depends on that. So we go ahead and do that, but we just record all that information. So yes, I'm sure crossovers are happening. We just have chose not to look at the data because it'll be very tempting to make premature conclusions.
Why? Patients for doing those crossovers? Try to guide.
We say, again, physician discretion, and usually it's escalation of care. You know, if you feel that your current level of support is inadequate, and mostly the answer is, I need to know if the RV needs to be supported. So we don't say, it's not mandatory to say you have to meet 1, 2, 3, 4, 5. We ask the physician to make that decision, but document the why so we can collect the why and understand it in a little bit more methodical fashion. But we don't tell them you can or cannot do it. We just ask them to document why they didn't. Yeah.
I think throughout, first of all, thank you for
Sure.
this great talk. I think throughout your talk, you've emphasized the importance of early recognition and early management, and that, you know, is from defining hemodynamics and phenotype to considering mechanical circulatory support. I'm curious because, you know, every patient is so unique, and the trial data are a little bit mixed in the use of temporary mechanical circulatory support. What kind of infrastructural components are necessary to meet the needs of the patient
Sure.
up front? And specifically, I think you mentioned you helped build a shock team at
Yeah.
higher institution.
So-
a whole shock team in that context.
So, you know, I did not talk about shock management here because that's a very different talk to say how to manage cardiogenic shock. I was trying to give you the overview of the field and the gaps that there are and, you know, that needs to be fixed. But to answer your question, you know, assuming the center they are at has all options available, because if the only option is balloon pump, then that's all you can do. You can have an academic discussion about you could have done this, but it doesn't matter. But let's say you're at a center like yours, where you have a whole array of options available. In that case, the key is, of course, 3 things: is understanding what the shock severity and phenotype is to begin with. What is the need for the patient, right? If the patient needs 1 liter of support to get over the hump versus the patient needs their own cardiac output is 1 liter, they need 4 to 5 liters of support because their kidney, their liver, their coronaries, everything is hurting. Then you can't marry that patient with a 1 liter of support, which is balloon pump, and then say the balloon pump did not work. You know, I was trying to avoid too many cheeky quotes, but Naveen would always say is pumps will do what they are meant to do. They will pump blood. It is your decision to use which pump for which patient. So to answer your question, you have to say, what do you hope the pump will do for the patient? Unload the LV, perfuse the coronaries, perfuse the end organs, all of the above, and then decide what to pair that patient with. Because if you can't quantify what you want this pump to achieve for the patient, how can you then say this patient should get this pump? Then you're going by a gestalt to say, well, 5-5 for everybody or balloon pump for everybody and so on and so forth. So to be as objective as possible, to define the need for the patient. But the key question, which my fellows go insane because I won't let them go till they answer this question: what do you hope this pump will do for the patient? And if you can't answer that, then you're just hoping it'll work, right? So you have to be able to say, I hope this pump will provide 3 liters of support, 5 liters of support, because I need their kidney, their liver, their brain, perfused, and I need it for a long duration of support. The third and most important key component is what is your exit strategy? Because if you have none, putting pumps, I'm sorry, is almost easy. It is how to take them out is much more difficult. So if the patient has no exit strategy, then you shouldn't be putting them on a pump. Now, in a shock scenario, you often don't know the exit strategy. So you have to, especially for younger people, assume that they will have an exit strategy. But these decisions after the first 24 hours have to quickly take into account what does the patient need hemodynamically, which pump can provide that with minimal adverse events, what is their exit strategy, and how long is it going to take? If it's going to take 3 weeks because you're hoping for recovery, you can't put them on a femorally cannulated machine, put them in the bed and say, hopefully you'll recover in 3 weeks. It's never going to happen. So all these decisions will come into mind before you say this is the right therapy for the patient. And the discussion, whether it's a shock call, of course, you can go on for an hour in a shock call that will get very, very annoying very quickly, is to be able to say, do we have an initial stabilization technique? And as soon as the stabilization happens, you have to start saying, what is my weaning strategy? What is my exit strategy? Whatever it may be. Because otherwise, you're just dealing with the day to day, which is what drives me insane. In many modern day ICUs, we just focus on the day, but it's like, how are you going to make this patient a better candidate for XYZ, whether it's weaning or advanced options tomorrow? Because if they're bed-bound NPO for procedure after procedure, not undergoing vascular and infectious disease badness, that's not success in shock. Then you're just putting devices for the sake of it. So it's not an easy question to answer, but you have to take into account. That's why shock needle is stuck where it is, because we have our internal biases, then we have our own fatigue set in. If it's 3 a.m., you're like, oh, just do this and I'll deal with it tomorrow. But that's where machine learning is gonna, Dr. Adamson's future algorithms are gonna tell you how to take care of these patients. Yes, Monica.
We've talked a little bit about this, and many of us were trained in heart failure, right? We're taught to manage these types of patients, but we're seeing this evolution in the care management model for shock patients. And as we move, those patients are now critical care, not so much heart failure management. What are your thoughts of the role of heart failure cardiologists going forward?
Is this meeting still being recorded? So I think, again, the politically correct answer is whatever is best for the patient. But beyond that, I don't think it is just one skill set this patient needs. I don't know how to do vent management, for example, or if they need chest tube or I don't know, ECPR, I will have to rely on my colleagues who have those skill set to be able to do that. So it's never going to be one ring to rule them all kind of scenarios. So there's two aspects of it, right? One, which is my personal pet peeve, is shock management does not end in the ICU. So first goal is to get the patient to survive. Of course, that's the key. But beyond that, nobody wants to take care of these patients, right? As they have a trach peg, they go to an LTAC, never to be heard from again. But we did our job, right? So that mindset I have a problem with. So when you want to own shock, you got to own the whole trajectory down to their outpatient follow-up when they come in with their groin stitches that nobody has removed and a PICC line that has been forgotten in there. So ownership for shock cannot be in the ICU. I'm sorry, that's the fun and toy part of it. You got to do it all or you got to do it none, I think, because these are patients. I have to think not just how they're going to do in the next 24, 48, 72 hours, a week, a month, 6 months, so on and so forth from now. So I personally think, again, multidisciplinary is the answer to all things wise, but ownership of shock, I've never had to sense about it, is with whoever is going to follow this patient for the rest of their life, assuming they live. Now, the other aspect for that's why I was joking, is the meeting still being recorded, is, university centers are protected partially from the need to generate X or Y thousand RVUs. And it bottles down to critical care has the highest associated RVU reimbursement. And that is going to become a battle in itself, is who owns it. Not to say that we do things because we want to generate more RVUs. That's not why I ran in CCU. I think I belong there, but that is an individual program to decide how do they want to balance that. Because I could see 100 patients in clinic, or I could do around 1 week in the CCU and generate the same number of RVUs. So there's other non-medical, non-patient related aspects which each center has to navigate. to say, okay, if it's gonna be just the purview of critical care, but the heart failure RVUs get killed in return, how does that get balanced out? Because I think we all have a role. Critical care has their role. I was the person in my previous center who started a critical care cardiology fellowship. So this is not to see us versus them, but our younger generations who are currently applying residency fellowships, they have a different mindset than you and I, Monica, is they want to do stuff and they want to go home and they don't want to deal with the follow-up sometimes stuff. And I'm glad they recognize that because we sure as heck didn't. And we keep telling ourselves we do this because we love it, but eventually it becomes a very financial, individual, hospital, organization-driven this thing. I just want to make sure that if heart failure is either pulled in or pulled out, they have a say in that matter. It is not informed to them that you're no longer a primary service. That I have a big problem with. Cool. Awesome. Thank you very much.